Chest pain, again, one of the very common presenting problems to the emergency department and actually to our offices as well. The thing that you have to remember about chest pain is that everything that causes it is not necessarily cardiac. And if you look at these next two slides, there obviously are cardiac causes. There are ischemic changes, pericarditis, myocarditis, dissecting aneurysms in the thoracic and abdominal aorta. But there are also other problems like psychiatric issues, panic attacks, malingering, especially in prison populations, factitious chest pain, respiratory problems like pleuritis and pneumonia. There are musculoskeletal problems like costochondritis, rib fractures, and chest wall pain after coronary artery bypass grafting. And then there are gastrointestinal problems like gastroesophageal reflux, peptic ulcer disease, cholecystitis, and biliary colic. All can be causes of atypical types of chest pain. When you evaluate a patient with chest pain, the first thing, again, you'll take is a careful history and physical exam. And if you look at that previous list, what you want to do first is rule out the serious causes. So you go ahead and look at acute myocardial infarction and things that will kill a patient, dissecting aneurysm. And then that gives you time to look at the less serious causes. Some of the pearls about chest pain have to do with misdiagnoses, and the misdiagnoses listed on this chart are things like ischemia or acute myocardial infarction in a low-risk adult. That would be a younger male or female patient, and we know that ischemic changes are missed quite often in younger female patients. Pulmonary embolism as a cause of chest pain is often missed. Malingering, factitious type chest pain and panic attacks, again, those are less serious causes, but they're often missed as a diagnosis. And then dissecting aneurysms of the thoracic and abdominal aorta. Some pearls with chest pain. First one is that patients who have known coronary artery disease who are recently hospitalized for chest pain may have another etiology, and that's often somaticization or anxiety. And how many people have seen the movie Something's Gotta Give with Jack Nicholson? How many times did Jack Nicholson go into the emergency department after he had his acute myocardial infarction? It was like the whole rest of the movie was him running in and out of the ED. Patients who are prisoners, how many people take care of prison populations? So they often exhibit malingering. They know that if they have chest pain, they'll get off work duty. So they go into the emergency department for that. The next one is kind of important, that elderly patients with acute coronary syndromes will often present with symptoms that are different than younger patients. So if you have an elderly patient in whom you have any suspicion of acute coronary syndrome, you'll want to work that patient up. Another good one, giving nitrates as a therapeutic test or giving a GI cocktail as a therapeutic test is not a great idea because non-cardiac and cardiac etiologies respond to both nitrates and GI cocktails equally. So you can't rule in or rule out coronary artery disease based on response to either one of those therapeutic modalities. The next one, myocardial infarction, can't be confirmed or ruled out, or that can be confirmed, but it can't be ruled out with a single set of cardiac enzymes or a single EKG. So if you entertain the suspicion of coronary artery disease and you order cardiac enzymes, you don't stop there. You need to do serial enzymes on those patients. And then finally, a patient who presents with chest wall pain, so you can feel along the costochondral junction and palpate chest pain, chest wall that reproduces their symptoms, doesn't mean that they don't have underlying coronary artery disease, so that can coexist. So don't rule out coronary artery disease just because they have findings of chest wall pain. I remember the first patient I saw with pulmonary edema. I was a third-year medical student at Wayne State, and we were doing our emergency surgery rotation. And this talk, I bare my soul to you, so you guys are going to learn a lot about my foibles as a physician, but this was actually as a medical student. So this guy came in, and he was in extremis. He had had a gunshot wound, and the senior surgical resident started 2 large bore IVs on the patient and said to me and another medical student, "You take these IV bags and you squeeze this IV fluid in as fast as you can." So we got on these bags and we're squeezing. We got 2 liters of fluid in this guy in 5 minutes. So we finished and we're standing there going, well, what do we do now? And the guy says, put some more up. So we put 2 more bags up, and about halfway through the second 2 liters, we look down and here's this pink froth coming out of this guy's mouth. And we realized that we probably ought to stop doing that. And so he had acute pulmonary edema, iatrogenic pulmonary edema. And the good part is that he survived. He did fine. You know, they diuresed him. He went to surgery. He did totally fine. So I guess, I don't have to worry about that being my first patient that I treated that died. That came a little bit later, I think. So what do you do for pulmonary edema? First thing is oxygen. Oxygen is the mainstay first-line treatment for pulmonary edema. Give it through nasal cannula or mask. You might use CPAP, and using CPAP in patients with pulmonary edema has been shown to decrease their need for intubation. Use furosemides or other diuretics, and what you do with furosemide is you start with a low dose and then you keep doubling the dose until the patient gets a response. And you can go up to like 320 milligrams or 640 milligrams in a single dose. It doesn't really matter as long as you keep on increasing it until you get that response. You can use vasodilator therapy like nitroglycerin or nitroprusside. Consider things like morphine, which assists in the management of pulmonary edema, and then things like Swan-Ganz catheters and Foley catheters to help you really assess the patient's fluid status on an ongoing basis. And then obviously, once you've stabilized that patient, you want to identify and treat the underlying cause. Now, there are a variety of things that cause pleuritic type chest pain, and that's chest pain that increases and decreases with respiration. The differential diagnosis on this list is quite extensive. We're going to talk in the next several slides about 3 of those problems, but things like pleuritis, pneumonia, pulmonary embolus, and pneumothorax, all of the more common causes of pleuritis. Viral pleuritis is caused by a variety of different viruses, adenoviruses, Coxsackie viruses. A number of viruses will cause viral pleuritis or pleurisy. Now, when you see a patient with pleurisy, you may hear a pleural rub. That's a transient problem or a transient finding that's due to the irritation or inflammation of the visceral or parietal pleura. About 20% of patients with pleuritis or pleurisy will have a pleural effusion. Again, that's a transient phenomenon and it goes away as the inflammatory process resolves. We treat pleuritis symptomatically using nonsteroidal anti-inflammatories, which decreases the amount of pain and over time also decreases the inflammation. And then the patient obviously will cure the viral illness on their own. Now, a severe type of viral pleuritis is called pleurodynia, and this is caused by a Coxsackie virus. It's associated with very high fevers and chest and abdominal wall spasms. Again, it's a self-limited disease, and we treat the patient by supporting them. So you use anti-inflammatory medications and any kind of analgesic that you need, along with rest, and then this problem will resolve on its own. Pericarditis is characterized by widespread ST segment elevation on EKGs. Patients will also have a pericardial friction rub, and that's a rub that occurs in conjunction with the contraction of the heart muscle. The first pericardial rub I ever heard on a patient was a patient with uremia, and you'll see on the etiologic list that uremia is indeed on that list. The pain for pericarditis will improve when a patient sits up and leans forward, and that's because the heart tends to swing freely within the pericardial sac and it's not rubbing against the pericardium when the patient does that maneuver. So the etiology, about 40% of the time we don't know, and it's probably viral, but a lot of other things can cause it. As I said, uremia, sarcoidosis. You can actually have malignancies of the pericardium that cause a pericardial rub and pericarditis. You can get pericarditis as part of the presentation of an acute myocardial infarction, or you can get pericarditis as a more remote finding, and that's called Dressler syndrome. Collagen vascular disease can cause it, and a number of drugs can cause it as well. To make the diagnosis, you do that EKG and you look again for the widespread ST segment elevation, and you can do an echocardiogram, which shows the thickening of the pericardium and the fluid present within the pericardial sac. We treat this based on the cause, but again, the hallmark initial treatment will be an anti-inflammatory medication, and indomethacin is the one that classically has been used for that. Radiation pneumonitis can occur anywhere from 3 to 12 weeks after acute radiation, and it's usually a windowed radiation for breast cancer or for lung cancer. The condition itself is manifested by a localized area of inflammation in the area of the window or in the area of the radiation. Patients present with a non-productive cough, shortness of breath, and a low-grade fever. Sometimes, if you do a chest x-ray or a CT scan, you can actually see the area of inflammation that's associated with the radiation port. Oftentimes, though, this is a clinical diagnosis based on the history of having had recent chest irradiation. There's not any proven treatment for this. Some people have used prednisone in an attempt to either prevent radiation pneumonitis or to treat the symptoms. It doesn't have very good success. But the good news about it is that it's generally self-limited. All of us who take care of asthmatic patients risk one day having a patient with asthma crash in our office. Now, some of the risk factors for people who will crash in an asthmatic attack are people who have had a previous history of intubation for asthma. So the patient who's been in the hospital and been intubated is at risk for having another crash in the future. The other problems that are associated with crashing asthmatics are asthmatic patients who use chronic oral steroid therapy and patients who've had a long duration of symptoms before they present to your office. Some of the things that you find on the crashing asthmatic are things like symptoms or shortness of breath at rest, conversational dyspnea, elevated respiratory rate and elevated pulse rate, and finally the silent chest. And the silent chest is an ominous sign for an asthmatic patient because that's associated with lack of air movement. So if you listen to an asthmatic patient's chest and they are exhibiting air hunger on your observation and you don't hear anything, that's a bad sign. So we'll start treating these patients with beta-2 agonists using albuterol continuous nebulization, or if you don't have a nebulizer in your office, you can use the metered dose inhalers. And about 4 to 8 puffs of a metered dose inhaler equals 1 nebulizer treatment. Sometimes you can give 1 puff every 30 seconds, and what happens with the albuterol is it opens up part of the airway, and then you give another puff in 30 seconds, and it opens up a little bit more, so you can actually progress the effect of the beta-2 agonist down through the airway. The next thing you want to do is use anticholinergic medicines like ipratropium or Atrovent. You give those either through a nebulizer or again through a metered dose inhaler. Then you want to add corticosteroids. Use 1 to 2 milligrams per kilo of Solu-Medrol every 6 hours. Remember that if a patient was on inhaled corticosteroids before you start the IV medication or the systemic medicine, that effect may be additive. Other things you want to consider is using IV magnesium, giving 2 to 4 grams over 20 minutes, which will relax the skeletal muscle and allow you then to aerate the patient better. IV epinephrine can also be used to